I want to turn it over to a couple of guys from SAMHSA. David Awadalla, who is on the Washtenaw Fan Advisory Board, and Chase Holleman, who, and I'll let you guys talk about where you're from, but David has been asking Washtenaw Fan, and me in particular, to do this for quite a while. And we had it scheduled for a different month, but it didn't fit. We wanted to make exposing the largest population of students and healthcare professionals and people in general to what David's and Chase are going to do, which is to discuss the resources that are available at the federal level to the families of people in recovery, to people in recovery, to friends of people in recovery. So you know how to access those resources, and especially during the month of September, which for those of you who aren't familiar, those of you participating online and streaming live on Facebook, this month is all about recovery. So that's, among other reasons, one of the reasons we wanted to get SAMHSA in here and our two guest speakers to talk about that. So you can learn from them and know where to go to access these resources. In addition to what FAN offers locally, they're going to talk about what's available at the federal level. So with that, you guys want to come on up. And Brandon, let's make sure we've got them where we can see all them, and we'll go from there.
Where's the camera? Is it that?
Yeah, I think that's it. Brandon, will you let us know if you can see them and what they've got? Okay, so you guys are going to be on, and yep. And I wanted to, I also, let me see it one more time, David, just to let everybody know, we had people from across the country request, hey, I don't have to show up, do I? Like if I just zoom in, can we do that? Yeah, you can do that, and you can stream on Facebook. But I even had someone from New Mexico representing a Native American tribal organization that said she was interested in learning what SAMHSA had to offer. And she Googled how to learn more about SAMHSA, and up pops Washtenaw Fan, which is pretty incredible. I guess social media sometimes pays, okay, to do it. And we do it here. So with that, we're grateful to those of you for participating, not only from our community, but from communities across the country. David,
awesome. Sorry, I just want to make sure that the virtual participants, can they see that?
I'm pretty sure.
Okay. Perfect. Okay. All right. This is great. Hey, everyone. My name is David Awadalla. I'm a public health advisor with SAMHSA. Also a former member of this community and have a lot of family members in this area as well. And a few of you showed up tonight, and I'm really grateful for that. This is like the perfect size crowd because it's like not too many people to where it's intimidating, but it's also like a pretty good amount because I'm just not freaking out, but I'm also like can look around and say, okay, I'm thankful this many people showed up. So I'm going to hand it off to Chase, but let's go ahead and want to move through the slides first. Spacebar. Spacebar is not working. Oh, it was off. The keyboard was off. Okay. So first thing we just have to do is do a disclaimer because even though we're here on behalf of SAMHSA, there's a chance we might say something that doesn't necessarily reflect the views of SAMHSA. It doesn't make a lot of sense, but it's required. And then we have no financial interest to disclose either, apart from my on the fan board. Next slide. So I mentioned I'm a public health advisor with SAMHSA's Office of Recovery, which is a brand new office that I'm going to talk about today and tell you about some of the resources. And I'm going to hand it off to Chase for a quick intro.
Hey everyone, It's really good to be here, and I appreciate the opportunity to share this space with you all, and commend the bravery of the folks who were vulnerable and shared about themselves. And it seems like you all have been doing that for a while, and this makes me feel connected. It makes me feel like I can be vulnerable, and I wanted to say I really appreciate that. I can really feel the community in the room, and it's special to be a part of it. I work with David at SAMHSA. As he mentioned, I'm a public health analyst there. And my job is leading the harm reduction efforts there. I live in a community called Greensboro in North Carolina. Before coming to SAMHSA, I helped found and direct a program there that provided harm reduction and recovery services and doubled as a clinical training site for social work students. So I'm glad to see all the social workers in the room.
Okay. So you guys are like, what are all these arrows? So it's just like a little story map. So most of you know that I'm not from Michigan, but I did go to grad school here, and that's how I got connected with most of you in this room. But before moving to Michigan, I went to the University of Georgia. Sorry, we thought we were gonna have a clicker. It's a little complicated. After I was at the University of Georgia for a couple years, I went on to be affiliated with the Georgia Department of Corrections, not in the role that you guys might be thinking. So I'll tell you about that in a little bit. So after I was not affiliated with the Georgia Department of Corrections, I went back to Georgia, was able to finish my bachelor's degree, kind of in like semi-recovery at this point. But then after I finished my bachelor's degree is when I actually found recovery. Went on to work at the state level for the Florida Association of Recovery Residences. And then I forget what comes after that, so you're gonna have to click it. I got affiliated with the Michigan Collegiate Recovery Program and got really invested in the community here. CRP and Matt and his team have done so much for me, and I'm very grateful for everything you've done. After I worked for and was a member of the Collegiate Recovery Program, I worked for a short time as a detox counselor at SPARA, and then also worked at the state level with the Michigan Department of Health and Human Services before going to the federal level, where I worked as a contractor with CDC's Division of Overdose Prevention and with HUD, helping with their pilot recovery housing program. And then finally, I came to SAMHSA. Now that's my boring like professional journey, but I'm going to talk a little bit about my lived experience as well. So this is why I do what I do. This is why I work at SAMHSA. You can see here, I have on the top, it says Clayton County release ID card. Everyone in the state of Georgia who's released from prison there gets one of these. And then it just, whatever county you're released from, it changes. And so I happen to be in a prison that was in Clayton County. The mugshot below that is the only one that I can find now. There used to be a lot more, but they've been buried by some good stuff, which is probably good for me, but I'm kind of sad that I can't find the old ones now, which it doesn't make a lot of sense. And then at the bottom, that's my GDC number, or Georgia Department of Corrections number. So 10,66908. And that was who I was for 2.5 years in the state of Georgia. And I want to acknowledge also like the privilege that I had. And I was able to access recovery support services, clinical treatment, medications for opioid use disorder. I had a recovery housing program to live in, so safe and stable housing. And I had family support, and all of those things resulted in my recovery, which now I get to do what I do with SAMHSA. But Mario was talking about people without resources. And I just want to kind of acknowledge that for a second, because so I was in prison with a guy named Tyler, and he became a pretty close friend of mine. We basically, for 2 years straight, we ate commissary together, listened to music, played cards, and, got worked to death by the prison system. We had to go out on detail and cut grass all the time. And he had almost an identical substance use issue to myself. So he, and that was kind of his drug of choice. And when he got out, he didn't really have access to the things that I had access to. And he had been in and out of the system for years. So we were both released in 2013. And I kind of heard either through, I like met his sister and some of his other family members, and I heard through them that he would be in prison and out. And then about 3 years ago, he reached out to me. And he called me this time from jail, and he was like, "Hey, you know, I'm about to get out. I'm like tired of doing this. I don't know what to do. I don't have any resources. Is there anything you can do for me?" So I reached out to some of my connections and was able to get him a scholarship to a recovery housing program in Florida. Now this is Georgia, mind you. So I started kind of trying to talk to his probation officer, because I didn't know what the stipulations of his probation would be, right? Well, I finally got a hold of his probation officer, and his probation officer said he can't leave. He's been mandated to a program in Georgia, so he can't go to Florida, and he can't take the scholarship. And he programs in Georgia that he can go to. So called around. They all had wait lists. Long story short, he got out. Too long of a wait. Went back to using, and then was on the run for 1.5 years. Okay. Fast forward now to about 4 months ago. He texted me from jail this time. So you can text in jail now. Couldn't do that back in 2013. So, and he said the same thing. He said, I'm getting out in 6 months. I'm tired. Help me. And so of course, we're all going to help someone when they ask for help. So I got a hold of his new probation officer, or future new probation officer. And they were really actually nice. And they were like, while he's not mandated to a program in Georgia, and he could technically go to a program that's not, on our list, he would have to transfer his probation to Florida in order, because this was felony probation for a drug charge. So we put in a request for interstate compact transfer. And this was 2.5 months ago. And it was looking promising. I was able to get a hold of the interstate compact administrator, and the probation officer was like, he has unique circumstances. And we thought it was going to go through. Denied. So we revised his application and put it in a second time. Thought it was going to go through. He got released 2 weeks ago on Sunday, and he was dead on Tuesday. So he got his second denial the day after he died. So even in death, he was being failed by the justice system, and by the entire system as a whole. And his sister called me his brother, who is a veteran, died 5 years ago from fentanyl poisoning. So we're losing people, and they're preventable deaths. And that's why this work is so important. So, for people like Tyler, that's why I do what I do, and I'm going to keep, making noise and pushing and pushing and pushing. And thankfully I'm at the federal level now, so I can actually make some change. So I'm going to hand it off to Chase now.
And I told you the first time you shared that, how much I appreciate it, and how I've seen it with my friends too. It's terrible. Sorry.
Oh, I was tagged as a hottie. I was doing my previous achievement. So, all right.
Awesome. So I really like this because it offers a chance to give some perspective and see where we're coming from and what our lens is. So my journey didn't completely start at UNC Wilmington, University of North Carolina, Wilmington, but it is important because the first recovery resources were offered to me there, despite me having absolutely no interest in recovery at all. In fact, I went into the Dean of Students office and lied and talked about how well I was doing, which wasn't very obviously not true. And they just smiled and played the gullible counselor. And I say all that because they did not have a collegiate recovery program yet, but they did care about people who use drugs. I was eventually invited to leave that university after overdosing in one of the dorms. But what they did for me is create a stipulation that I could return. And that's important because had they not done that, I would not have been eligible to ever return to a UNC system school. So I appreciate that harm reduction that they did for me. After UNCW, shortly after, I was invited to join the Wake County Jail in North Carolina after being arrested on some pretty serious felony drug charges. And I too have to acknowledge my privilege, especially my melanin deficiency, the resources that my family had to get a lawyer to put me into quality treatment and start help changing my life. Some of the things that helped me would be naloxone. I mentioned overdosing at the dorms. I overdosed 5 times during my use. Naloxone saved me a number of those times, and I'm really grateful that I had more than one opportunity. That's all right. Also, what helped me was the medication buprenorphine. The first time I took it, I remember feeling a sense of normalcy that I had not felt in a very, very long time. And it kept me safe and doing well for a little while until my medication was discontinued abruptly, and I returned to use the next day. Next slide, please. I'm going to fast forward recovery. I mentioned being eligible to return to a UNC school because of what they did for me at UNC Wilmington. That school was UNC Greensboro, where I got my bachelor's of social work and where I was introduced to collegiate recovery for the first time. In fact, I was their first student ever. And my world was really small at this point. I'd been in recovery and doing pretty well for about a year at that point. And I didn't know much. Eventually, I saw a movie called The Anonymous People, of which Andre was in. And my world got a lot bigger because I saw people who were like me, who were being vulnerable and talking about their recovery. I legitimately didn't think that people cared about people like us. I didn't know that there was a movement, that there were people working really hard for decades at that point to make sure that folks have a chance. I really appreciate that. Thank you. Shortly after that, I also should mention I went to UNC Chapel Hill for my MSW and benefited from a collegiate recovery program there, which I'm super grateful for. Continued on and worked in outpatient treatment for a little while. I'm a licensed clinical social worker and addiction specialist. So I spent some time doing that, working in inpatient as well. Eventually, a naloxone distribution program in my community, benefited from the work of the local drug user union, who taught me a lot about harm reduction, and was able to start a post-overdose response team and syringe service program and a number of other programs there. And I mentioned earlier that doubled as a clinical training site for students, which eventually brought me here to, well, I guess here, to SAMHSA in my role now. Yeah.
All right. So, yeah, quick objective overview. So obviously sharing our stories is important. And so as 2 people that have been impacted by addiction, severe addiction, you know, we want to make sure that we talk about stuff that's going to benefit everyone, both that's on Zoom, on Facebook, and then all of you here in person. So there's 3 objectives today. We're going to kind of touch on a couple more than the others. So in addition to giving you guys an overview of ADA protections and why and how substance use disorder or people with substance use disorder and those in recovery are protected by ADA, we're also going to how we and other federal staff use their lived experience at the federal level, not just as SAMHSA, but other federal agencies as well. You know, we have partners at ONDCP, which is part of the White House, at CDC, and they often use their lived experience more than their professional experience, which is really, really important. And then also we want to share some resources with you, and that's probably the most important objective for today. Okay, so just a quick overview of HHS. Real quick, who's familiar with the HHS org structure? Anyone? Kind of, sort of. Yeah, I know Dave's definitely familiar with it. The Department of Health and Human Services is it's a pretty big organization, and within HHS, there's a bunch of different octaves. And I'm going to go through this really quickly, but in addition to SAMHSA, we have CDC. Our main partners there are the Division of Overdose Prevention. We also have HUD, which I mentioned earlier. I work with them pretty closely. We have CMS, the FDA, the Association of or Administration of Children and Families, and or NIDA, the VA, and then finally HRSA. And most of those agencies have either grant programs or resources for people with mental health and substance use conditions. So, and each one of them is unique in the objectives and the target populations. So, and then I mentioned other agencies outside of HHS. So ONDCP. We also work with the Drug Enforcement Administration, which is part of the Department of Justice, and a few others. So, and then a real quick overview of our org structure. So I'm in the Office of Recovery, which is just kind of under the Office of the Assistant Secretary at SAMHSA. And then Chase is in OPI, or the Office of Prevention Innovation. These are brand new offices. They just opened up. So the Office of Recovery is about a year old. OPI, I think, is about 2 years old. And so SAMHSA is actually considered a smaller agency, but we do have quite a few staff there and quite a few different centers that try to achieve different things. So there's a Center for Substance Abuse Prevention, Center for Substance Abuse Treatment, CMHS, or the Center for Mental Health Services. We also Statistics and Quality Center. And so each of those has different objectives, different goals, and different priorities. All right, I'm going to hand it off to Chase real quick.
Thank you. And real quick to think about it, because it's so much alphabet soup at once. SAMHSA is the Substance Abuse and Mental Health Services Administration, which is a part of the Department of Health and Human Services. So our main job is to administer grants through states, as well as discretionary grants that go out to people who put in applications. And those dollars are primarily, or all go towards mental health and substance use treatment or services or prevention, a number of things. So background, I've got a photo up here from International Overdose Awareness Day. This was 3 or 4 years ago in Greensboro, where we had a number of family members and friends and people, loved ones, who came to honor people they had lost. I'm tired of sharing this slide. We're on track for the 3rd year in a row for over 100,000 people to die in this country of a preventable of overdose. I'm tired of it. Is this me too? Yep. Oh, yeah. Overdose prevention strategy. The screen is very small here. And forgive me, y'all. I am very tired. I've been up since 4 o'clock in the morning to get here, and I'm hanging in there. So thank y'all. So we talked about the Office of National Drug Control Policy, ONDCP, which is a part of the White House, the Biden-Harris administration. So at the beginning of their administration, they announced an overdose prevention strategy that has 4 key pillars that you can see on the screen here. And what's really important about this is, for the first time, one of these key pillars is harm reduction, which we are going to talk about. This is a historic step for the federal government, who has been 30 years late to the party to support harm reduction, and a great step in the right direction.
So this is just a quick overview of SAMHSA's priorities and guiding principles. And we actually just released our 2023 to 2026 strategic plan. And as you can see, we have 4 different guiding principles that are outlined in our strategic plan. So recovery, commitment to data and evidence, equity, and then trauma-informed approaches. And then within each of those guiding principles or across them, depending on how you want to look at it, we have different priorities. So preventing substance use and overdose, integrating behavioral and physical health care, promoting resilience and emotional health, specifically for children, youth, and families, strengthening the behavioral health workforce, and then enhancing access to suicide prevention, mental health services. And each of those priorities and the guiding principles apply to all the centers, but each priority lies within a different center for the most part. So next slide. So we were talking earlier about lived experience and the value of lived experience. And, you know, there's been quite a few papers released recently about the impact that it makes at the federal and state level. And it's also defined. So how it's defined by, actually, this was a paper released by ASPE, which is part of HHS, or the, I think it's the Assistant Secretary for Planning and Evaluation. So many acronyms, but it's basically knowledge based on someone's perspective, personal identities, and history beyond their professional or educational experience. So, and obviously today's discussion, we're talking about lived experience associated with two main things, and then the things that might come with that. So substance use, mental health, and then, you know, I have lived experience with the justice system. Chase has lived experience with overdose. And so each of those are unique in their own right. And therefore we can bring a unique perspective and help advise some of the work that we're doing at the federal level in our own unique ways. So you can go to the next slide. Oh, that is the next slide. Okay. It all looks the same. As I mentioned, and I just said this, that we're talking about lived experience associated with recovery from substance use disorder and mental health. But I also want to now acknowledge the power of people with living experience, specifically people who use drugs, right? So they often get left out of the discussion. And, you know, there's some reasons for that. But however, let's be honest, like I've been in recovery since 2015. I barely escaped when the fentanyl was getting into the spot. I have my own unique lived experience associated with that. Who here has heard of xylazine? Okay, keep your hand raised if you've injected xylazine. Great. So you probably can't tell me anything about xylazine apart from what you've been told by other people. However, people who use drugs or someone that might have just entered abstinence-based recovery 3 days ago or a week ago, they can tell us what it's like to inject xylazine and the consequences that come with that, right? So it's important that we have their voices at the table. They are seen and they are heard. And far too often they're left out of the discussions and left out of oftentimes even the recovery community, because we do put such an emphasis on time in recovery. And, you know, just because someone has been in recovery for 1 day or 1 week doesn't mean they don't have anything valuable to contribute to the work we're doing to reduce overdose and save lives. So I don't know, you want to have anything to add to that?
Sure. I'll just mention, especially in terms of harm reduction, that the reason that we have harm reduction today is because of brave individuals who fought for their own lives in the late 1980s during a growing HIV and AIDS epidemic, who it was the right thing to do because government was not acting, went out on the street and started giving out syringes because they knew it would prevent the spread of HIV. And how important that is, how people who use drugs were the first to distribute naloxone to community back in 1996. People who use drugs have gifted the world with many things, especially a lot of our public health programming that is aimed towards people who use drugs, and just how important it is to have the people at the table that you're talking about. It'd be kind of awkward, right? You know, if someone were to walk in and we're talking about their experience and what they need. And it's also just practical, as David talked about, to inform programming.
So real quick overview of what incorporation of lived experience and living experience can look like. So there's a few different ways it's done, both at the federal level, but also at the community level. I'm sure a lot of you know about clinicians or peer support is based on lived experience. There's clinicians that have lived experience and might use their lived experience either as a family member or as someone in recovery. Interviews and focus groups are a valuable way to collect information from people with lived experience. Partnership is active when you actually have them at the table with you. Leadership, either in an advisory way or organizationally. In a minute, I'm going to tell you about some of our leadership that have lived experience and are open about it. And then finally, staff with lived experience as well. So all the way throughout the organization, there's different ways to incorporate. So on the screen right here are 4 different federal leaders, either current or former, that have lived experience associated with substance use and have told their stories. So Deb Haaland is the Secretary of the Interior under the Biden administration. Tom Coderre was our former assistant secretary. He's now the acting deputy assistant secretary at SAMHSA. He worked for Faces and Voices and was in the Anonymous People and has told a story over and over and over. He was a senator out of Rhode Island that used to smoke crack and go out on the Senate floor and speak. His story is compelling if you haven't heard it. Michael Botticelli, the former head of the ONDCP at the White House, convicted of a DUI. And went on to lead a federal agency within the White House. So and then finally our director at the Office of Recovery, Paula Del, who's been pretty open about his story related to both substance use, also mental health conditions and the struggles that he faced with being homeless on the streets of Philadelphia. So next slide. And so Chase mentioned some of the things that we should thank people with lived experience for and living experience for. So peer support services, 12-step groups, syringe service programs, community-based overdose education, naloxone distribution. The list goes on and on. All this stuff, Mario's lived experience. This is all possible because of that. And it's important to amplify that and nothing about us without us, right? We're not going to fix the problem without having people in the room who actually know what the problem is like. So next slide. So now we're going to talk about OPI and I'm going to hand it off to Chase.
So the Office of Prevention Innovation was mentioned. It's about 2 years old. This is the Federal Register announcing OP being created. Next slide, please. I'm going to rush through a lot of these probably. So we do a number of things at the Office of Prevention and Innovation. One of those is program evaluation. We oversee all the technical assistance that happens at SAMHSA. We'll talk about a number of those technical assistance centers in a little bit. And what they can do for you and your organizations, subject matter expertise. So harm reduction, myself as house there, David with recovery, who is the liaison to recovery, lots of external requests, center performance, and grant oversight. So basically, we're looking at everything and trying to make it better, right? To advance what we're doing and to innovate. So you can just see more of the stuff that we do here. Next slide, please. So switching gears here to harm reduction. So I mentioned just 2 years ago, harm reduction was announced for the first time as something to be supported by the federal administration. Shortly thereafter, the first thing we did was consult with people with lived and living experience and experts across the United States. We did that by having a virtual harm reduction summit in December of 2021, where over 100 experts joined us to help us define harm reduction in the context of the federal government, knowing that harm reduction had long been that we were late to the party again, and to help us come up with a vision for harm reduction at the federal government. What does it look like? What are the practices that we can support as the federal government? What are the principles and pillars that guide that? Next slide, please. So out of that came a steering committee of 17 individuals, the majority of whom had living experience, a lot of them with decades and decades of harm reduction, prevention, recovery, and treatment experience, who synthesized a document, a summary of those findings, gave it to us, and eventually that turned into a harm reduction framework which is the first document of its kind to guide the Federal Department of Health and Human Services in harm reduction. You can see the definition and some stuff, an overview of it up here. It was recently posted for public comment. It is in draft form. That public comment period has closed. Currently, we're taking all of that feedback and making changes where necessary and where important to be released at some point. So in this document, the reason it's important is, as I mentioned, it's new to the federal government, right? And sometimes we're slow to do things, and everything needs to be written down and defined for us to do that well. Also, when we're selecting grant applications, it helps us know what is good harm reduction. What does that look like? How do I know that it's working? What is a program going to be able to show it's effective? And we framed harm reduction in a number of ways, and that's important because it can often be reduced to one thing. A lot of people think about syringe exchange programs when they think about harm reduction, and a number of other things. That's a really reduced way to look at it. The major ways it's a philosophy. It's an approach to working with people that values autonomy and the dignity of people who use drugs to make self-guided, self-directed choices to make slow, positive change in their life. I have a list of some of the services associated with it, and then also entities. So I talked about the brave individuals of the late 1980s who eventually formalized and created organizations nationwide to help facilitate and do this work largely unsupported for the last 30 years. I mentioned pillars. So these are important to guide harm reduction. So again, the inherent value of people, being guided by people who use drugs, which we've talked about, promoting equity, rights, and reparative social justice. So harm reduction, as much as it was a response to the HIV/AIDS epidemic, it was a response to racism and a racist war on drugs that was disproportionately incarcerating Black people and people of color, other people of color, committing to deep community and community building, offering the lowest barrier access and non-coercive support, making resources available to people where they are, and giving them resources that they're wanting to take and do. Focusing on any positive change as defined by the person. People don't change overnight dramatically, not very often. So celebrating any positive change someone makes. That can be using one syringe one time and greatly reducing their risk for HIV, Hep C infection, or other deadly bacterial diseases. And celebrating that and watching the slow change happen over time, which I've been privileged to witness many times, I've been privileged to happen in my life. Next slide, please. 12 supporting principles. So just diving deeper, respecting the autonomy, providing support, prioritizing listening, valuing practice-based evidence and on-the-ground experience, both. Connecting family, biological or chosen, as this audience definitely knows, the importance of assisting, not directing, promoting safety. And you can read them all here. Next slide, please. So it also defines some core practices that the federal government can support. I won't go through the entire list, but I'll go through the subjects or the categories of them. Can you go back a slide, I think? So safer practices, I mentioned syringe service programs, overdose prevention programs like naloxone distribution. Next slide, please. Safer settings, so access to safer environments where people can find respite and learn how to practice safer using habits, where they can connect with people with lived experience, people in recovery, counseling, supportive techniques. A lot of people who utilize harm reduction programs, that is their only medical touch point. They see no one else because of the discrimination they face. I was talking with someone earlier and how we both know people who have chosen to die of a very treatable and bacterial infection because they were treated so poorly in the hospital and they refused to go. So it is so important for that medical touch point to offer that setting for people who use drugs, people experiencing homelessness, and all of the things that can come with it. Next slide, please. Safer access to healthcare. So creating those transition points. If you're the only touch point for someone, you are their access, you are their bridge to healthcare, providing that, providing buprenorphine treatment, Suboxone treatment, methadone. Next slide, please. Safer transitions to care. So making sure that a continuum is unbroken. Again, meeting people where they are, being out in community, being by and for the people. If the people are part of your program and help design it, have equity and a stake in it, then they're going to see it through, right? They're going to create that community. Next slide, please. Sustainable workforce and field. So this one is just making sure that harm reduction can continue on and that the people who work in it are supported, as they largely haven't been for 30 years and experience trauma every single day. Next slide, please. And a sustainable infrastructure. We can go to that one. So I've mentioned a bunch of times community-based harm reduction programs. So this is important that we name this and support this. As I mentioned, people with living experience who started these interventions are often left out of the conversation, often left out of funding streams, often left out of resources, and have had a disproportionate positive impact on the work despite this. So naming that and being supportive of organizations where lived and living experience represent the majority of people serving at that organization, which I also heard about today, which is awesome. Next slide, please. Next slide. I mentioned harm reduction new to be supported. That included a harm reduction grant, which is historic, as these federal funds and none others ever can be used for the purchase of syringes for the use of drugs. One of our grantees, the Detroit Recovery Project, is in the room. That is who we did a site visit with earlier and really got to show us how beneficial it can be for recovery community organizations and harm reduction programs to work together. We have 24 other grantees across the United States doing some really fantastic work. Next slide, please. And then the National Harm Reduction TA Center, which I'm going to let David talk about.
Awesome. Thank you, Chase. Yep, here you go. So, yeah, yes. Yeah. Yeah. So it wasn't question. So you want to here.
Sorry. I just wanted to, so 450 agencies applied for the harm reduction grant, 25 were eligible to get it. And that's really important, is that it's a demand across our country and it's not being met because we see it as it's like kind of like a stigma and like a moral issue. And so it's not that people don't want it. And I think that's really important to acknowledge. And I just wanted to say that because it's awesome that we funded 25 people, but that's not enough. That's all. Sorry.
Yes, thank you. Thank you, Amanda. That's that was a great point. It was only $25 million, 25 recipients. But oh, that's a trip. So the slides disappeared. Oh, did you press? Oh, okay. They're back. Okay. Okay. Woo. Okay. Pause.
Yep. Real quick, for those of you who have questions online via who are participating via Zoom, just put your questions in the chat feature. Brandon's going to plug us into those questions and we'll get to them once the guys are done with their presentation.
Yeah, we're going to rock through this next part. And if for some reason we don't have a chance to get through all the questions, our contact information is in the slides. So for the people online and the people here in person, feel free to reach out afterwards. So real quick, the National Harm Reduction TA Center. So can we get back to the Harm Reduction TA Center slide? Is he going to do it? There we go. Okay, great. Yay. All right. Losing the audience here. Okay. So this is a pretty awesome resource. So it's free. This is a partnership between SAMHSA and CDC. And it is a website where you can go on and you can request free training or technical assistance related to harm reduction across any setting. So let's say you're an RCO and you're looking to learn how you can incorporate or find funding to incorporate harm reduction services in your community and you don't know how. you could request free help with this resource, and they have the leading subject matter experts within their network of trainers and TA providers who will set up one-on-one calls with you and walk you through that process until you're able to. So this is a growing resource too. It's getting bigger and bigger and bigger. We're expanding the TA provider network, but the leading subject matter experts, National Harm Reduction Coalition, NASTAD, these are like thebomb.com for harm reduction that truly are invested and will help you figure out how to bring that resource into your community. So next slide. So that's backwards. This keyboard is tricky. So the Office of Recovery, just a really quick overview. I mentioned we started about a year ago, and what kind of kicked us off was a recovery summit where we revisited SAMHSA's definition of recovery and developed our goals and objectives. And so you can see we're established to evaluate, initiate policy program services with a recovery focus. And then we've also convened a bunch of meetings, dialogue sessions that are informing our efforts as well. You can kind of click through. And then finally, it's not just myself and Chase, but a lot of people at SAMHSA, but almost all of the Office of Recovery have lived experience associated with substance use and mental health. Next slide. So just the prevalence of recovery, you guys see 7 in 10 adults who had a substance use problem consider themselves to be in recovery or recovering, and 2 in 3 adults who had a mental health issue feel the same way. So this is not a rare thing. Recovery is everywhere and it's for everyone. So next slide. Who's familiar with SAMHSA's definition of recovery? I know you are. Anyone else? Cool. Okay, great. So it's a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. But that's, if I got that definition wrong, it's gonna be embarrassing. Nope, that's right. So this is keyboard. Okay. Here. Okay. So we also revisited this working definition of recovery during the summit, and 150 of the leading subject matter experts in recovery confirmed this definition. And you can see here that it doesn't say anything about 12 steps. It doesn't say anything about smart recovery or celebrate recovery. And it is a process of change that leads to positivity and growth, right? Everybody's recovery is unique. And that's something important to recognize in the recovery community as a whole, that my recovery might not look like yours, and that's fine. And it doesn't make anyone else's recovery any less than ours. So if someone is in what they call natural recovery, maybe they don't do AA, but they're striving to reach their full potential and they're happy and they're healthy and they're in recovery, and that's fine too. So I mentioned the meetings. We've had a lot of dialogues that are informing our work at the office. So we had a dialogue session between students with lived experience and university administrators to inform our collegiate recovery efforts. David Seaman, Matt Statman was there. So we had a lot of in that room to help us inform and develop our action plan surrounding collegiate recovery. Andre, who left, was at our criminal one. That one was amazing. It was about 75 people, that most of which had been incarcerated, about 20 or 25 probation officers, judges, parole officers, and people who work in the court correction system. And we talked and we figured out what needs to be done so people like my friend Tyler don't die. And these meetings, we kind of realized we're not going to be able to do the work without engaging our community. And so that's what the purpose of these. We also had a tribal recovery summit in Dallas, which was, I didn't get to go to that one because it was the same time as another one. But from what I heard, it was amazing. And we have developed a really, really robust action plan. So each of these meetings also produced a report that we're using now to expand our work. We also developed a national recovery agenda during our recovery summit, and that is to forge partnerships to support all people, families, and communities impacted by mental health and substance use to pursue recovery, be resilient, and achieve wellness. We have 5 goals that guide our work: inclusion, equity, peer services, social determinants, and wellness. I'm going to fly through these just so we have time for questions. And then finally, these are some policy changes that have happened that have really increased the awareness of recovery and people with addiction. So the supported block grant name change, and it changed to substance use prevention, treatment, and recovery. Support block grant, recovery was not in there before. Grant recipients are now being required to account for and report on their funds that are spent for recovery related services. And then finally, the establishment of SAMHSA's Office of Recovery. Now, who in here, I know Jermaine, you're a peer recovery coach certified, right? Any other peers? You're a peer? Any others? You at any point? Yeah. Great. Okay, so we have a couple of peers. So the national model standards were kind of like the Office of Recovery's first gold star, I guess. And it was one of the first things that we were tasked to do. And we were actually tasked to do that by the president. This came about from his unity agenda. So in his 2022 unity agenda, he outlined ways to basically expand the peer support infrastructure in the nation. And so he outlined the development of a national model standard for certification, because there's so many different certifications across each state, and we needed some uniformity. So we developed the national model standards with these key applications in mind. So the biggest one, and I'm just going to mention that one, it's the first one, to encourage reciprocity. So people like Molly, if she wants to move to Nebraska and practice peer support there, she doesn't have to go through the peer certification process all over again and pay for a whole another process and take a whole another test and do another 300 hours of training or whatever their requirement might be. In New York, it's 2,000 hours of required work experience. And then I think it's like several hundred hours of training. So each state has their own unique barriers. So we're trying to kind of encourage that reciprocity and get some uniformity across the different certifications. And I'm just going to run through this really quickly. So we also wanted to be clear what we meant by national model standards. So that's a standard that promotes quality and consistency across peer services, limits barriers, is based upon guidance from the peer workforce, and is grounded upon existing practices. How much time do we have left, Mario? Great. Oh my gosh. Okay, so we're gonna skip through. So let's skip through these. I'll just say model standard 1, the whole premise of peer support, lived experience, right? And so, there's been some issues with the authenticity of peers being diminished by people that don't have lived experience becoming peers. I wouldn't want, if I was entering recovery and someone who was a peer tried to talk to me and they didn't have the lived experience that I had, it wouldn't be helpful for me, right? And so that's the biggest and most important model standard, is that states make sure peer supporters have the appropriate lived experience for the people that they'll be serving. Okay. Skip that. So resources. This is where we're going to talk about other resources other than the harm reduction TA centers. So slides are out of order, apparently. ADA. So this is just a quick slide on the protections that ADA affords us. We are protected by ADA when we're in recovery and not using illicit substances, and that is clear. There's also certain things that we are protected through, specifically employment, transportation, public accommodations, housing, and I also want to mention that telecommunication. So ADA is not only for people with substance use disorder, it's also for people with disabilities. So for example, closed captioning. So, but SUD is protected, mental health is protected. So if you're in recovery and you're discriminated against because you're in recovery, that's a violation and it's legal, and they can be fined thousands of dollars. And on the ADA website, you can report violations and they take them very seriously. So. Finally, resources. This is where I'm going to share some links with you all that you guys can visit afterwards that will point you in the right direction. So first off, we have a whole Recovery Month toolkit on the SAMHSA website. You can also learn about the offices, both OPI and the Office of Recovery. And then we also have a list of all our TA centers on the OR website as well, but I'll run through those right now. First off, findtreatment.gov. I'm sure you're all familiar with that. It's a repository of treatment centers, recovery programs, recovery-oriented systems of care, and you can use this treatment finder to find help for people. The Peer Recovery Center of Excellence, I mentioned before, the TA Center, Harm Reduction TA Center. This is similar, except this is for peer support services and expanding and establishing peer support services in your area. The ORN, or Opioid Response Network, this is for I think our SOAR grantees. And, but I also believe that the general public can use it as well. And then our Suicide Prevention Resource Center, similar. And then finally our TTTCs, which we have one for each center. So the Addiction Technology Transfer Center, Mental Health, and Prevention. And all of these are available to the general public. So you can request help if you're either struggling for a loved one, or if you just want to learn about what you can do in your community. And you can also reach out to someone at SAMHSA if you're not sure which center to use, and they'll point you in the right direction. And then finally, our tribal TA center. Now we had a couple more slides on the intersection of recovery and harm reduction. Should we just skip those and go to questions, Mario? All right, let's do it. Yeah.
Hi, I'm sorry. One thing, we've been making a lot of claims up here, and some of the folks watching or some of the folks here might be wondering, how do I know that that's true? Website, you can find peer-reviewed sources that cite all of this, cite decades of evidence supporting what we're talking about. And I also wanted to say one important thing about technical assistance. Before working for the federal government, if I heard about a technical assistance center or some website, I would have been like, yeah, great. What does that do for me in community? What's important to note is that the National Harm Reduction TA Center, it's not just a website. Anyone in this country can go there and create a request, even if you think that it is just somewhat relevant to harm reduction, and get direct live TA from experts who have done harm reduction in all kinds of various forms in all kinds of community and are from community, and can give you direct guidance, direct TA on how to do that. If you are watching and you are in a small community and want to learn how to distribute naloxone, you can go there and find someone who can help you do that directly. Just wanted to add that. Thanks.
Thank you, Chase. We will be providing not only a copy of presentation, the PowerPoint, but of the recording. So you'll be able to reference this. If you participated online and registered and signed in over here, we will put you on our listserv, and you'll get a copy of the presentation. And you guys mentioned your contact information is in there in case anybody wants to drop into a different level of detail. Okay, with respect to harm reduction areas, has there been an increase in crime in those areas? That's a great question that I'm sure a lot of people are asking about. One of our guest speakers, you guys, from a few months ago was an expert from Portugal, and he addressed this as well, but I'll let you guys.
Yeah, thank you so much. This is an important question as people in community are wondering about how to keep their community safe. As I mentioned, there are decades of evidence. People have asked this question for a long time and looked at this. There is no association found with an increase in crime in areas that harm reduction programs have been set up in. In fact, pretty much all harm reduction programs assist in removing litter, especially syringes that are improperly disposed. These are things that are already happening in the community that harm reduction is taking a positive stance to resolve. So the short answer is no, there is not an increase in crime because of harm reduction being introduced to an area. And then I see, do you want me to answer this next question? So I'm going to go ahead and answer this next question. It says, is SAMHSA working to legalize syringe distribution in potentially safe use sites? It is still illegal in Michigan even to prescribe clean syringes. So it's important to note that the federal government has no comment on overdose prevention centers as long as there is pending litigation going on with the federal government. And in response to legalizing syringe distribution, I think this is an important question and something that people ask a lot about SAMHSA's authorities and powers. So SAMHSA is a federal agency. We do not have the power to change laws. That power is reserved for Congress and lawmakers. And not part of our authority. We also get asked about our name being substance abuse and it being stigmatizing, also a regulatory or a legislated matter. So it's important to know that these powers, how money is distributed or how much money is distributed, that is all the job of Congress and not within our authorities.
I'll also add that in many cases, it's up to the state as well. Chase mentioned SAMHSA's authority, and not only can we not change laws, but we especially can't lobby to change laws or change laws at the state level. And each state has their own unique laws surrounding harm reduction and syringe service programs. But right now, federal funds can be used to purchase and distribute clean syringes. And that's
With that one grant.
with the harm reduction grant. Yes. However, there's other federal sources of funding that can be used to expand harm reduction services, just not be used to purchase harm reduction supplies. So for example, CDC has an OD2A grant or overdose data to action, and they use those funds for evaluating syringe service programs all the time. So okay, so David Gordon says the film Body Brokers released in 2021, written by John, based on factual realities, expose unforeseen consequences of elements of the ACA intended to expand access to care, but becoming a massive opportunity for predatory opportunists. Yep. Has this problem been addressed effectively, or is this an ongoing pathway to take advantage of victims? Yep. Okay, so I can definitely answer that first part. I'm very familiar with the body brokering and the fraud, urinalysis fraud that was taking place and is still taking place, just to a lesser extent, especially in Southeast Florida, Southern California, where treatment and recovery housing programs are really, really prevalent. And so what I believe David is referring to was a fraud scheme between recovery housing programs, detox centers and treatment centers, where people would just go through a cycle and they would be signed up with the insurance policy that would reimburse the most. And then they would pee in a cup 3 times a day, and then their insurance would be billed upwards of $2,000-$3,000 per your UA. And that was a huge issue. As far as SAMHSA, going back to federal speak, that's not in our authority. However, SAMHSA did work closely with our state and other federal partners. Most of the cleanup happened at the state level, though, and it falls under the responsibility of the state. For example, South Florida formed the Sober Home Task Force, which shut down a lot of the unethical operators and actually arrested them. There's one who was sentenced to several decades in prison for not only urinalysis fraud, but actual body brokering, where they were essentially abusing the patients that were going through their treatment center. So I think that's most of the question. And then he says, is the prevention discussed meant to be overdose prevention or addiction prevention? Both. So the Center for Substance Abuse Prevention, we have 2 divisions, the Division of Targeted Prevention and then Division of Primary Prevention. Primary prevention has grants that are focused on preventing the onset of substance use, so early and moderate substance use disorder, while the Division of Targeted Prevention is a little bit later down the line and is more overdose prevention oriented and harm reduction oriented. Chase, you have anything to add to that?
I'll just add that primary prevention still maintains to be a primary focus of SAMHSA, that we believe in a big tent prevention where all of these things are welcome. We know that these issues don't exist in a vacuum. and support community who are working to prevent dangerous misuse of drugs, as well as prevent the harmful effects of drug use that is already happening to people. So the answer is always both and. I also see a secondary question. Yes, a follow-up about the harm reduction TA center, sending people to nonprofits and or university clubs to do trainings. As far as in people, I can't speak for them. They do trainings for those organizations, and any organization, individual. I highly recommend just going to the website and putting through a request and see what they say.
That they definitely will do trainings. They might not be in-person trainings because they might not be needed. It just depends on the specific TA requests, where it's coming from. If you're an organization in Hawaii, it might be a little bit more difficult for them to come out there, but they will at least do virtual trainings, which are oftentimes just as effective, especially initially. So. No. So it's refreshing. Any word on the VA standing by their previous authorization to operate SSPs at many VA facilities? Syringes can only be accessed through prescription. Naloxone distribution through the VA also still has many barriers. Yeah, so can't speak too much to the VA because they're a different federal entity, but I can say naloxone is now over the counter. So, but as far as getting or if you are a veteran trying to use VA funds for naloxone at a VA center, I'm not too familiar with that process. I don't know if Chase is. So I'll hand it off to him to see if anything that.
Again, reiterating, I don't speak for the VA. Hello, Lucas. Thank you for the question. I think I can speak on good faith that the VA would be interested in hearing from you if you have questions and thoughts about syringes and naloxone. So reaching out to them would be a great thing to do. I think they would love to hear from you about it.
And if you don't know who to reach out, you can reach out to us, and we have colleagues at the VA that we can connect you with to answer those questions specifically. So.
Yeah, I think we've covered most of the questions. And if not, know that we're going to have Chase and David's email addresses, contact information on the slides. Okay, so we're going to give that to you guys. Is there anything else by way of the presentation? We've wrapped that up. Okay, we're good. Okay, so we're going to wrap things up, but I want to talk about, thank you, Chase. Thank you, David. You guys are awesome for coming here. Really appreciate it. Stick around. Yeah. Okay. And so I want to talk a little bit now about the next couple of meetings that we're having. Next, let me try to find this here. Next month in October, one of the things that we try to do here at Washtenaw Fan is bring up the most interesting subjects that we think will be of the most value to our community. And I know that Fan, two leading mental illnesses that we deal with when we make a referral to help someone, with either inpatient rehab, outpatient rehab, the two leading mental illnesses are depression and anxiety. And so we went online. Who is an expert on anxiety? At least that was where I was going, because I know a lot of people who are anxious. We are all anxious, okay? But to the extent when you start getting into needing help is when that anxiety prevents you from living your life, okay? So I went online, typed in leading experts in the United States on anxiety, trauma. Something like 2/3 of the people affected by the disease of addiction have suffered some form of trauma, be it, verbal, sexual, you name it, it's there. And if you don't work through that, your recovery is going to be very challenging, impossible. So lo and behold, this expert pops up, but he's not from California, Massachusetts, Florida. He's from Detroit. He's from Wayne State University. And his name is, I'm going to butcher this last name. I don't go by his last name because I can't pronounce it, despite him telling me numerous times. But his first name is Arash Javanbakht from Wayne State University. He's an addiction psychiatrist. He just had a book published this month called Afraid: Understanding the Purpose of Fear and Harnessing the Power of Anxiety. And I'm looking for, I'm going to go off camera here, but he is our guest speaker in October. That's the second Monday. I don't know where my paper is, but yeah, is it right there, Ange? So the title of, yeah, it's right there. Yep. Thank you. So the title of October's forum, and the reason I mentioned the book to those of you who are still here and to those of you who are participating online and streaming on Facebook, is that we're giving away copies of his book. And that's no small cost to Washtenaw Fan. The book is pretty expensive. But if you participate here or you register online and give us your mailing address, we will mail you a copy of that book after the presentation concludes. Dr. Arash is going to be here. I think he's participating live. So just much like David and Chase were doing. So he's going to talk about that. And we hope you'll be here. Okay. Or participating via Zoom or streaming on Facebook. So if you want a free copy of a very interesting book that will hopefully help you pull through if you're suffering from anxiety or trauma, as I mentioned, most people have experienced when they're dealing with an addiction, join us in October. That flyer detailing how to participate, the date, the time, will be emailed to everyone over the next week. Okay. And I'm just noticing, Chase, not only do you have colorful socks on, but so do I. Okay. There we go. So anyway, look, the November meeting, I'm just going to talk about this briefly, is on loneliness. And the reason we picked to deal with that subject is that the holidays are approaching the following month. We have a national speaker from North Carolina joining us remotely. They've got resources that they can avail to everyone who's participating. And I'll never forget the side of the president or CEO of Blue Cross Blue Shield said that they commissioned research on the single biggest contributing factor to relapsing, and it's social isolation. Okay. So don't be alone. If you're in recovery, get out there. You're going to learn resources to battle that in November. With that, I just want to thank David and Chase again for coming here. Yeah, we appreciate you guys. And, you know, David Awadalla is another guy who was there for Washtenaw Fan when no one else was there. And we appreciate that, David. And we appreciate you bringing this guy along with you, Chase. Thank you very much. So look, we look forward to everyone joining us next month. Look for that flyer, and thanks for coming. Take care, everybody.